Are you there?
Yeah, start.
I think are yet to join, no?
But we can first, we are not sure.
So Dr. Yeah, talk is of no.
Sir, if you talk,
I think he's
you can
I have done every on this fine. About society to Shakti policy. Today is first Dr. Vishal, Dr. Sharma and Devanand. You have the talk of Devanand with us.
so, will be present.
Yeah, yeah. Go to Dr. Devanand with you. Dr. Deva. Keval here.
Oh, hi,
Hi.
Dheeraj Chalim.
I can name.
Yeah, he's not as well as video. So we his video continue. We can share the next of the video. Is that fine?
Move to next one.
Yeah, we'll do this I talk. You want the come and this as because we limited here and we would want some time. Okay,
Yes, go ahead.
and share. Can you see now?
Can see.
So, good afternoon. This Metronic on technology in surgery, specifically about an redefining the way metastasis surgery has been done. I'm also going to include some cases where we've done open surgery and where it does. What is essential? A lot of confusion in people's mind. So a lot of people use Google Map to travel. Map will essentially give you, or for that matter, any GPS system will essentially give you all the possible ways to do it to a destination. The obstructions you best way. Similarly, a navigation tells you the safe corridor possible impediments and the possible dangers in putting your instrumentation, and it doesn't just restrict the instrumentation, it's also something that has doing more than just in school. How do we get information need to be gathered? Patient sitting on a surgical table, and that OR is basically a CT which gathers information running a scan. It is real into this navigation that an S8 navigation. So this is a 3D ready navigation which takes the information, and there's a small tracker here if you can see here. So this is the it establishes the anatomy body. Makes it easy. I'm just some still pictures before I show what happens real. You are able to take in an optimal path of your screw should be without having to open. This is especially very, very important in minimal access surgery. You are able to take in the longest possible screw. You are able to take in the fastest possible screws accurately, having a risk of going out and required your time screwing in this allow you non-metronic also. Metronic screws are seen the best because each one has its own digital footprint, this navigation. Also, it retains memory. This is important in multiple levels, especially when doing scoliosis. So you screws that you screw is a little bigger as compared to the curve that is going. So you can actually put them in, put them out so that your reduction and your rod goes in much. Well, it's also useful in anterior work where you can actually see your trials go in, your shavers in, and see your cage going in. Can be so the chance of keeping cage proud, I'd say, looking into the canal too far into the anterior space. These are important things. Not happen every when it happen. Things that fragile happening. These are surgery image. How does this? I'm just going to how it goes. Case you take an CT scan image of the patient on table, and that is fed real time to the system. How does it work? So in this case, you are looking at the screen while operating, not at it is something that you get over in a couple of cases. You have to keep the navigation part, navigation screen in front, and look at it and operate. So this is how we do. This is where I'm to mark the optimum entry point of the screw in an MIS case. I've already finished my this work. So this is me marking the skin, and this is what is happening on the screen real time. So the blue mark is the panel that's in my hand, and the yellow is the projected going to take. So once I have marked my entry point, I know where to take my incisions. This has enabled us to take more lateral entries. It has enabled us to put in a more medially traversing screw and longer and fatter screw. So that's the cut. As I'm putting my needle in and the picture, you can see this traveling real time into the patient. As I'm going through the deep fascia now, I'm push through the deep fascia, that's where I'm going in. You can see 3D, that's where it has landed. It has landed. Just check the position of the length of the screw I'm going to put it, and then I'm hammering in. As I'm hammering this in, I can see real time where it's going. I can correct the way needle is going. So there are no errors in putting that inside. It is as simple as that. This other projections that you see, that's sorry, that's an hospital announcement going on in the background. See your instrument being going. This is at tab in. That's a real-time screw that's going in. So it's very comfortable knowing where you're going, having to open a patient. This is what keeps it simple. This is what keeps it safe. Does it extend on my surgery? There are two other options. One, what you're seeing here is a lateral mass incision. In this is I'm drilling through lateral mass, seeing in all three veins that I'm getting in at the correct place. So you know you don't have to worry whether your screw is or it's too small, because a small screw in lateral mass is used, and a long screw can go and a lot of other structures. This is a classic Lenke maneuver. This is an ankylosing spondylosis patient. I'm going to start this from the start. The thoracic to pedicle to reach. You can see there is hardly pedicle, it's corticalized. So Lenke is now facing out. I have just pedicle border, and now I have reversed the Lenke and I'm going in again. I'm going in again. I know exactly where I'm going. You're using your local anatomy. You're not going to be able to feel medical gifts. This is a place where you actually hammer it in, and knowing that where you're going is seen in front of you, it's a safe way to it. So this is how cool it goes. Lenke facing out. I'm going through a pedicle that completely corticalized, going through it, and then I have reversed Lenke, and again, this is what does to your surgery. It makes that safe. This is it's important. You can see here, grade list 3, trying to get a S1. It is if you have done that, when you do this, you have to actually ram it through. Now, the very sclerotic end there. So this is my Lenkate I am taking exactly to get a tricortical case there. Once this is gone, you know exactly the length of the screw that's going to be bicortical. That is where this makes difference. It's in the difficult cases where this is going to make difference. Another, it's not just instrumentation. Example, this is osteoid osteo. We couldn't use vulgarated radio frequency device because you can see it's quite close to the cord. It's lumbar junction. Reach here, ideally pass it out and fuse it with screws up and down. We didn't do that. What was done here, I'll just show you. This is a O-arm image. That's my probe. I have drilled around the osteoid osteoma through the bone here. And once I have drilled around the bone there, it's just easy things for you to take it out. And that's post procedure image where I have drilled that, and that's the osteoma taken out. That's not the one case wonder. This is another case about an 18, 19 teenager. That's what we did for him. That was the one project where the osteoidoma is. That's where my first navigated dilator. We dilate 16 mm tube, and through that 16 mm tube, you can see the focus and post-op image here. That's what we took out. So this is a dramatic difference. That's a small tube. You can see here in the patient's posture before and after the surgery. This is a giant tumor, 38-year-old paralyzed lady, quite big, had to do decompression with stabilization. That's what we did. That's what we went from behind, put in those screws, then took out this whole two construct to take out the tumor as much. And then we went in front. You can see the aorta, the lung, the heart there. And what is important here is removing the tumor. This is the projection what I'm doing from the microscope on the navigation, and that's is this. How much have I removed for the tumor? So I'm just moving it through to see that removed and excised the tumor as possible. It's another this capability where we do it generative care. This is a fracture. So this is a fracture. That elderly lady, kypho, had a lot of pain. What we on the other side, hand side, you can see this conventional images. What enabled us to this is blue. That is what I see here. This cage in the on the side without having taken outside of the agents. This dramatic of a new, and also say because the cavity compromise canal. This is another moving safety the vision of your so on table you can add the amount of you can see the are much better in 2D. Far more complexes like where the of backs with the kite could risk and put 70 or this man had a previous surgery steno where we do and retain the permission. You can see birth is 39. It's an 80 we operate, and that's clinical for surgery. This more than 2-3 years surgery. So this is my advantages of navigation in convention, but access also for a patient. And if questions, I'm very happy to answer. In time.
Yes. Full question to you is you operate in you any of your cases do a history of plant.
So the most when you do thorough planning is says bad or a kyphos. of course, that's done. We have pre-op anymore unless congenital scoliosis. Do we want better printing or something? So and as we more and I have cost more 400 now. We are now doing our job city thing, but this is tells you instrumentation. No other. I think doing there.
Right, right. You cages, so it's the help of what other import cages?
So you get all cages. Problem is newly in 18 degrees where the navigation is, but they have come beautiful titanium nanocoat, which we just time back. Actually, trial and be navigate. You can navigate uh, for plastic and kypho can navigate part of right. So you don't for 30 rays shots you take your whatever plastic. What happens? You say, oh, radiation is cannot. Your patient is operated life. You stuff this for 4 decades. So patient surgical zero. So that's the biggest advantage. If you see my hands here, the head is palm. I used to hold while passing this thing. One thing that is, I'm outside when this forearm goes on and gives me the image, and when I'm doing it, it's all navigated image. So you have to think about and your team's safety, because anything wrong with them will discourage people from doing good surgeries. A lot of people say, CT radiation is so. In an conventional CM, the amount of radiation taken for coronal screws is phenomenal. A better way of less it. And I mean, open surgery, I would not like on that discussion because only fools and open surgery and minimal access.
Yeah. Thank you, Vishal. I'm checking my hair and I'm here, I think, moving forward.
Absolutely. It's thing I would request, but it's not to Mercedes. But in your OT, you spend majority of your day, you should have that at your
Yeah. So thank you again. I will invite my next speaker, Dr. Devanand Degulmadi. He is a spine surgeon at IB Hospital, and he's been on the you mentioned the nanotechnology age for future. Over to Dr. Devanand.
Yeah, good afternoon. You're able to see my screen?
Yes, we are able to.
You're able to see my screen, sir?
Devanand, we are able to see the screen. Go ahead and your top.
Yes, yeah. Thank you. So sorry for that. I am Dr. Consultant Spine Surgeon.
Devanand, not able to see screen. You are able to see your camera. To share your screen.
I have shared my screen.
Technical team, can you help Dr. Devanand?
While Dr. Devanand is getting his screen sharing done, there is a question, Kshitij, where do you on the side? See, if you are lateral mass, usually it's from C to C7. In such cases, put it at the C2. If I'm doing a C1 C fusion, I put it on the C2 spinous process, because that's where it usually gets the most. The C1 screw is usually safer to pass C2. I put it on C2, even if there is a movement because of C2 vertebra remains accurate in its project. When you are doing an occipital cycle, then and again it remains C2. You have to remember the more difficult tracking is going when you're doing a thoracic and surgery, doing a long school, because the thoracic vertebrae will up and down with the ventilation of the lung. So that's when a minor error margin creeps in. In such cases, the further go away from the tracker, the chances of error become. So you should put one tracker in the lumbar spine and one tracker thoracic spine. Take 2 scans, and then you have more accurate. I hope that answers the question, Kshitij.
We are able to see screen, Devanand.
Yes, Dr. Devanand, you can see it now.
Okay.
Yeah, thank you.
So I'm going to talk about this adaptive synthetic system, which the Medtronic have recently launched in August. This is a titanium black surface technology. So as we all know, the body fusion technique have been evolved from graft alone to titanium cages and then cages and probably back to the titanium cages again. There's few as techniques of the inter it done with the bone alone or olive cages with the approach retroperiton nowadays. Open system with the knee cages with the type of cages in that system. There are various cages available with the shapes, sizes, the angles, and even the coated are also available. And these cages have tested times. Have recently come this 2020 European Spinal Review, which shows that titanium cages may be superior to peak cages in lumbar in body fusion. It's systematic review concerned when comparing titanium versus peak. So after this nanolog system has come in, we have gone to the literature. We have got the literature, the Spine 2012 journal. It compares the osteoblastic cell response, which they have compared with titanium, rough titanium, and the peak cages. And they have come up with this conclusion that the osteoblast, they exhibit more differentiated phenotype and also increased production on the titanium alloy substrate than the peak cages. Osteogenic environment and osteoblastic maturation is more in the rough type of titanium or when compared to the smooth type. The other spine, which shows that the osteogenic and angiogenic responses have in the titanium alloy compared to the peak. And seen this increased bone formation, enhanced integration, and improving the implant stability. All these factors are of the surface-related expression of integrins, which are important in the collagen recognition, thereby increasing the angiogenesis support and reducing the osteoclastic activity. The next gen in 2015 in the Society of Biomaterials, and they have studied the hierarchical structure of the titanium implant surfaces. They have done this using the scanning electron microscopy, in which they came to the conclusion that appropriate microsurface and nanosurface, it yields a highly desirable surface for rapid integration of the bone and interface. So this was one more journal. So journals, they say that the case have an advantage because it has the modulus similar to the bone and also fluorovisibility. But this in the spine, it has a disadvantages of fibrous encapsulation. So the peak case, it promotes fibrosis, thereby causing micromotion, subsidence of the cage, and also non-union. All these things are overcome with the titanium cage, promote the osteopathic factors. So the new implant system, which is promoted by the Medtronics, it has the following features. It has a smooth Dolphin nose, will the distraction of the body space while inserting. It's quite easy to insert, and it also has a honeycomb, as you can see, the nano surface seen, and it also has a lot of area for the bone insertion. By increasing surface with the end plate, it minimizes the stress load on end plates, decreases the subsidence chances, and the osteoclastic pits, the pits you are seeing because of this nano technology, double the osteoclastic pits. Thereby, they increase the angiogenesis as well as the bone formation. So this has been released by Medtronic in we had nearly cases, and this is an example of a 45-year-old male as erythrolysis, and she was in a lot of back pain and bilateral leg pain. We have operated using my MISS. And this case, we have just called the follow-up. This was just 2 days back, and the CT scan done in the arm, which we have. This shows a very good bone. I cannot say that it is true, but the bone formation and the new bone seen on the CT scan post-op, it is quite good. And is doing quite, and is able to her daily activities at the end of weeks. So case 2 example, similar case L45, which is we have used the nano system. Case 3, similar case of L5. In case 4 of L5 lesion, which has been treated with analog system. All these cases post-op, they are absolutely happy. And one more advantage is system, it's clearly the post-op X-rays, and in the post-op follow-up X-rays, they're able to see the bone graft clearly. In all these cases, there is a follow-up of at least 6 months in order to say that the bone is good. We can compare the PEEK cages or the titanium cages. Thank you.
Yeah. Thank you, Dr. Devana. It was a very informative from you. My question is, how do we compare tantalum cage with nanotechnology?
The nanologism which they have come up with, they have the face changes which they have made it, and the data says, the journal say that the osteoplastic pits, they resemble the osteoplastic pits, and the other, which is not in the other cages are introduced till now, and this promotes and increases osteoplastic activity as the fusion or the which is seen normally at the end of 3 months or 6 months at other cages. They say that it see earlier in these cases, probably 3 to 4 weeks.
Doctor, there is a question. Is there any change in the grafting protocol since you have started using adapt?
Till now, all the MISS cases we have used this nano system, or 5 in the 5 cases, and we have used the local bone graft. We have mixed it with the iliac crest. We have just aspirated the iliac crest and have put in some iliac crest bone graft. Otherwise, we use the regular local bone graft in MIS.
Okay. So, is there any advantage? This has a particular snub nose. Sorry, it has a how to say fine
nose. Yes.
So, are you able to put larger cage as compared to say capstone?
Yes, sir. Absolutely. Especially in alpha S1 MISS cases, like see the anterior disc is opened up and the posterior is usually collapsed.
Yeah.
So in these cases, struggle to put in a cages.
Okay.
If you put a smaller cage, it goes anteriorly and it becomes a sort of loosened.
Yeah.
So in this, we integrate it, and once we keep hammering it, it goes in very fit. We have used it under navigation, but we are the supported insertion part. Probably it will be great in putting.
Thank you. Thank you so much.
My last question.
Yeah.
You mentioned minimizing this on the end plate. The mother cage.
If you see the face of the cage, have very nano. It's not rough surface, not the smooth surface. So amount are there on the exterior and interior surface, they cause damage. It's like it's not smooth, but neither it is rough. Minimal damage when it is entering, it goes flush to the end, and it doesn't cause much of abrasion of the end plate.
Okay.
So what he means is other rough edge cages, they have a larger inside. So when you're ramming cases inside, they are likely to damage the end more. Here, the size of grain, or rather that is there, is so small. That is a nano. It resembles robotics, the of a cancellous stone. So while getting in, chances of this slipping into the end plate is less. I think we should next week. Thank you for that information, Dr. Devan. Next one.
Dr. Sharma is a consultant in hospital. He'll be working on anterior.
Is one of the theory of evolution, and behind that is a truly surgery of the tissue dissection, and the patient morbidity is less, and results are predictable to those lumbar spine. So in the past, we used to see pathology. The option which come to our, we had to do levels anti-cervical fusion was in a discectomy, putting out the either metal or peak cages and anterior. So most of the time the graft kind of removed from the crest. In the recent major changes happened at my practice, that instead of using plate cage construction, I have moved to even for the pathologies, and then using the crest graft. Most of the time I am locally available. So the example of like 1, 2 level, 3 level is being treated on cages. So so it's a real minimally invasive surgery. We require dissection in proximal dimension as mediolaterally inserting any. There is no implementation to the in the operative period, and all things ultimately leads to recovery and discharge of the patient to the hospital. So if you look at the, so I'll just quickly go through the procedure part quickly. So this is the position which we, the orthopedic spine surgeon, we tend to left the neck using an anterolateral approach. So the tube will always, the endotracheal tube will always come from the right corner of the mouth, does not interfere in your functioning during the surgery. If you can insert an or Ryle's tube for better effects. Nowadays we have moved away from it because we try to feel, and most of the time we were feeling was a thyroid cartilage. So nowadays we don't necessarily put it, but if one wishes, they can put an artery also. You can see that the shoulders are pulled down. What especially in these stout patient, and if you are on a lower level, C6, then you will be able to see level very well on a Siam shoe. So you have to put these shoulders down. Seen from the left side, you can see that roll of sheet placed under. So this neck little bit, so this space a little bit clearly, and the while fixing the cervical will be in little bit lordosis. So you fix it more position. I don't the tongs or garden or traction. Even level pathology required, I intersegment extraction using the Casper detectors. We use one of the naturally available cases of the neck, so post-operative will look better. Draping kind of limited. The exposure part of draping is limited to the area of and just to be exposed necessarily have full exposed. So the rule of thumb at the level of thyroid cartilage, if it is around C5 or C5, and cric cartilage around C7 or C5, 6, operating at a higher, your incision will be at higher level. For the exposure, first step, they put a straddle in the disc and we keep position and take first lateral to from the pathology. Case we were targeting C6 and the needle C6-7. It's very important from the occiput down to the index area, because if you are not coming at the top, then you might the level and then operating on at level. The retractors, so there are multiple retractors available in the market. For multi-level where bigger, we would commercially routine retractors, but we have developed new retractor uh, um, like this. So this is like typical color retractor, but instead wider blades on the side made the thinner plate. What happened that some for especially for level pathology is so small that bigger not go in for retraction. We have these as well as plate uh, proper retraction, and if required, you can this is open by retracting both the plates. You can small um, right angle retract position in the line. This is a Casper retracted place, and there it looks so both the pins will go inside vertebral body to the under construction, and then you open it. So you can see that on the left hand side of the screen, the pin body, and it is in non-directed position. But right side you can see after section how much that can open up. So it will make surgery go a little further, and sectomy will be easy. In the bone graft, so you can see that how much bone graft is able to retrieve just by removing the anterior osteophyte, sorry, uh, anterior inferior osteophyte to the superior vertebra and the posterior superior osteophyte to the lower vertebra. Most of the time, we have to retrieve enough graft, and it's been a while since I have found the iliac crest graft for a simple degenerative disc. So you can see on the right side that even after filling up the page, we see a lot of bone graft. So there is no dearth of bone in from the operating itself. Two instruments very important are the angle drill and angle screwdriver. Because with that small thing, you are not able to insert the screw big trajectory unless you have these instruments. Otherwise, big struggle, and you will have a tendency to kind of go parallel to that plate, inserting the screw rather than oblique to. So this is how the drills be drilling, and ultimately need to be at this angle if you want to be in the correct trajectory. And that's one example of how the screw goes in with that kind of screwdriver. Now you have done the dystomy and spinal cord decompression. Your son is in. After the surgery, as you can see on the side, your cage is already in. With the angle drill, you go through the cage and make your and once the right upper side, how the screw is in the middle part. The other option is the screw provided is self tapping and self, so you can put the screw in the lower without uh, and this is how the final picture looks like. Do you have time? So you can go through.
Yeah.
Okay. So incision is hospital in the neck region. For the 3-level pathology, we are able to kind of uh, deal with this incision only. So once you cut, you come across the layer of the figure, staying on front side of the cleidomastoid lateral to the trachea. Then you dissection with the help of your and with the a peanut on the at the very Alice. Once you the spine dissect prevertebral fascia, after cutting your so this needle going inside the disc. Once you your then mark this with too much. You mark very important to the disc. Other of move, then you lose your disc which you put the needle. You will expose the surrounding and the bone with the help of routine curette move the, and before doing that we take out inferior and inferior osteophyte upper vertebra, that will be using bone graft. That's what is we are right now. The advantage of doing this step is that you get a stress to the disc and that closing, which might improve or of the um, removing this of the vertebra. This is give the bone for the proper the cord. Once then your pathology to see whether there is any extruder. In this case, if the extruder the left side, which we using a hook. Uh, Once then to go posterior PA and then and through that till another the disc for the fragments are quite big. The cervical get enough through that neck PLL we insert a 2 mm and then remove the fragment. We can see that that is now through the uh, through the precision which we have done. On your pathology to check the height as well. I mean, word of that if you go lateral, then you might bleeding. So this is the size in. Once the sizure is in, you know what size you put this bone filled cage inside, then insert screws. That's it. Thank you very much.
Yeah. Dr. Amit, it was nice to listen from you. Question was, go to school link, which cases prefer to use?
Just this which I showed you with the this case itself.
Okay.
So I inserted that image so that we have that also available. Otherwise,
Okay.
I don't.
Nice. I prefer same. Yeah. Other questions?
So we don't have any questions, and for lack of time, we're just on time. Can we go on next talk?
We'll call Ayush from Central Hospital. He's a master in surgery.
Thank you, Dheeraj, for such a nice introduction. Continuing the session, let's start with the talk on OLIF, which is the lumbar interval fusion. So I'll start with the small video technique just to show how we do it, and then maybe go to a few cases. So this is a single position OLIF. Single position means we did everything in one position. So a 49-year female with back, and you can see L3 for there is significant amount of lumbar is happening as well, and you can see the CT scan in part slices and significant disc degeneration. There was a scoliosis and mismatch in the lumbar as well. So we took the lateral decubitus. This is how the skin looks like. Roughly 3 finger anterior, but that can depend upon the patient which you have. In a thinner patient, you might be slightly near. In a fatty patient, you might have to go much further. So if we have marked cranial and the content, and this is the incision. See this incision 1.5 or max sometime up to centimeter, and that is the incision you take. You can see the finger. I mean, it is a pretty small incision, and only thing you will see I'll clear is the skin, and rest thing will either split will go through. So the facial external oblique. Of course, we cut the fascia as well, and that is how it is. This is the fascia of external oblique, and as we go to the abdominal muscle, we'll just see the muscle and keep splitting the muscles. There's nothing absolutely which will, and that is what makes it a minimally invasive approach. So you, as we go layers which are the external oblique, the internal oblique, and then after this go through the facial transversalis, and you can appreciate the change in action of the muscle as we go. So even if you some reason you don't want remember them. Just keep looking the way they split, keep looking at the five, and you go splitting it, and that's what we have been doing. The last is the fascia, the transverse abdominis. So again, this is the next. Again, you can appreciate the change in the direction, and that is what all you need to do. Look at the change in the direction. And last layer is a thin flimsy, the fascia salis. You can use your to just make it. So I'm using, because very very layer, so I'm using finger break the layer. This is exactly what we do. Once we go in, palpate psoas. So psoas, is a very big muscle, so you cannot. So use your finger to palpate the psoas. And as I make just dissect it using a finger, I'm. This is how what I'm doing. I'm palpate psoas. Over this, I put the hand in tractor. So I use these special tractors with conic shape, and they exactly go over my finger. What it does, allows that doesn't creep in. This is all what I use. So once I palpated the saw, I know my saw at the tip of my finger, and then I have slided that tractor just finger. This again, I'm making sure that I'm right where I want to be, which at the saw. And then I have taken out the muscle, I'm exactly directly looking at the sauce. And this is what you see that now the other goes in, and and you can see the swab in front of you. So what do we go do whole surgery at 360-degree view? We don't go with the C approach, which is really taught. That has really, we feel that has made our surgery safe. Now, sure, this was and nothing else. Sometimes there could be so many things. I'll show you out here. Here you see it, just anterior body sauce, a white structure, which was a femoral nerve. If under a reason, you can really important structure. That's why it is very important. Do it under that reason. You can see anterior to the anterior the psoas, cord-like white structure, which is a femoral nerve. That's why now to even dock tubes directly reason we do it blindly as recommended additionally. This has really helped us avoid complications, and you can aberrant art, everything. What we do when there is something, we use this and retract, we just push the and then put our handheld back. So we nothing but only space which and again reconfirming everything. And once we reconfirm that there is no other white structure around there, that is the time we'll put our we just confirming the same. And once we are sure that 360 nothing is happening, there's nothing at all. That is the time the first tubular system happens. So docking is not blue, it is completely under vision 360-degree. And that makes it very. And once we then the dilated goes in. This is how the dilate goes in. It will sort of dilate and give you a space to work. And this is the final later which goes in. And this is the time when I handle the so then we confirm, well, this before you can see the list is still there. And then start doing your dev. So you find again, so many time people ask, how can you remove? You can see everything. You can see it is like doing a CDF surgery. Now everything is under, then you do nothing else, and you do what you want to do. Important, very good, pure carrot thing. When we use the shavers, you can see shavers going. You have to or maneuver to make sure that or the space. And if you see, I'm the way I am going. I'm not particular interior and just what we want maneuver, because you're going through the oblique corridor, but basically you want to put your cage perpendicular to the end plate. So this is what as orthogonal, and as we go in slightly gradually this space. This is the page you can see going in through, and this is just to show the placement of the, and this is how it. You see already the list is completely used. Even had to, and page going in, and see you. This is, and you remove your system, everything will fall back, because basically you have not touched anything. You're just hitting the muscle. The muscle layer simply falls back, and that only anterior. Then in this particular case of augmented with the posterior, and see there is already where you have put it is reduced. In this case, we did a single position, that means lateral we could put this. So that was advantage. Now almost all one level, sometime two level, we can do it single position, so that in the lateral position we put the screws behind. So what it is showing, the whole is the single position. Literally reduces your time of the surgery, and you can see post-operative MRI showing the good decompression, and this is, see there is a good compression coronal plane as well, and this is your post-operative X-ray. So, and this is the post-operative showing good realignment. So just this is basically, they say it is direct decompression, but I think this is a direct decompression because the pathology was the listhesis, and there was a buckling of the disc causing the compression on your spine. So once you have put the cage, you have solved the primary problem. This is what happens when we do that. See, we completely achieve our balance. This is 6 months follow-up. This scan, so good solid bone trabecular 6 months, because the size is really for a very, very good bony or bone tract. So this is what the is, and this is what this is how, like the uh, the X-ray picture is the incision, as we told you, it's 1.5. Do I have to show a few cases, Dheeraj?
Yes, yes.
So to show you, so why only? This is the way. This is where we feel it does make a difference. Case like this, if there is a scoliosis, kyphosis, there is a post-ectomy defect, and there are many ways to skin a cat, and you can do something. But I think the best and the least invasive way, the OLIFs, because it really allows to get more out of the level. That is how I see. So this you can do. You can correct scoliosis. You can restore the lumbar and the indirect compression. This is what that patient. Now we have a follow-up, solid bone, and really done very well. Another where I live was solution, because there is a segment disease previously instrumented case. If you do anything, you the implant and then do thing. The patient was really painful. He was really dancing with pain with every step. What we did was we did a standalone. So the cage, and we put the plate along with the, and there is, you can see only blood which happened the revision surgery. And again, so as you can see plate which is there on top of, and all with, that's it, and how it looks again are almost 3 her, and she has really done well. This is a scar surgery, and this is the only thing which you in a case in a segment. So that's the OLIF in certification. It really, and this is walking post of date, because really, and we have gone tried to end the bond. We are doing degen. This is a 2 degen scoliosis. You can see the just by we put this, and this correction. Again, you do try more and put more. The post nectomy is 70-year female. No one we did level, and this is he looks like, and you can see the alignment, the movement, the lumbar, the thorax simply go. And now yesterday, see, 1 year, 8 years, he has really done well. 1 year, exactly, 19th game, really fusion. I didn't, I couldn't, but it will come. X-ray. I think he has most few. These are the thing is a kind of view testing instances. Thank you.
Ayush, the excellent presentation. There are a couple of questions for you, and we have 3 to go. But the one question is, what is your substitute you use? Second question is, Dr. Devan asking you what is that you have used in this lift. The third question will these two.
Yeah, I'm using they're using calcium gate. What I have been using. You have many options. BM is the ideal option. B really expensive option. Maybe we should use it, but hospital can't afford it. So silicate is some properties is like a so it really fits very well lift cage. That is what we're using, and we have very good even at 6. We are seeing good bones and at around 11,000, and you can use up to levels in month of pretty decent Indian market. So much so that I was fine and debut big way calcium silicate. Just nationally launched calcium at a very high price. But what I've been using is from Novo. I think it's a company that does it, and that was is a Indian scenario is a decent. So plate.
Have you did that?
So it is a plate which comes with the there's a the electronics box is with the plate, the inbuilt just need to it comes with the cell.
Wind up. Last
Yeah.
question I ask is,
Yeah.
when you're saying that, how pedicles 60 purchase in using it in own measurement adjacent osteoporosis and in elevation. So what screw you use? How long do you use screws, and how is the purchase?
So to be not some recommend my cases, we very critically about of the 4 cases I only one where I so you be very selective for the reason you earlier, not as a at this disease traumatic there's no stress low segment. I think get away and that we have in and you predict this in the various but length were used
To get a purchase with
no
this
you right whatever
much, I should wind up. I have been in.
Yeah. Question to you. Thanks for now. Well, and can you tell me can advantage over this?
so for example already a laminate thing still issue because need to the scar. I'm still a foot cage doesn't give much of can you we can enter. This is where you need more showed you need more of the level my use. Am my main
Thank you very much.
Over to Kshitij.
Very much, Dheeraj, moderating, and I would like to thank our sponsor, sponsor shop and sponsor this entire do their store on in your conference app, and at this work, and I like to invite organize the sector of the online society. Satya, all of you produce this. Oh, Satyam, are you?
Here, looking at both. So I invite to hall now. We're doing our session. We have same thing hall. We after this again back halls. Uh, session in we've had uh, uh, Devesh. Thank you. Uh, 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 thank you to its participants. We could right from 13th, 14th, where we had very good operative sessions of techniques. We've had very good participations and a lot of delegates who came in and